Hi, I am Dr. Munoz and I'm going to talk to you about how is generative AI impacting workflows in hospitals and for physicians. And my perspective is mine only. Hopefully you get some pointers. If you are looking to buy a option out there such as a Bridge, Frit, Mariana, Savant, any of them, if you're looking to buy one of them, I can tell you that all of them are very similar. They are very similar in which you activate the phone, you activate the computer, and the software is starting to recognize your voice and your patient and the conversation. And because it has been trained to identify those parts of the conversation that create a note, it will create a note. Now, there is a lot of interest in this in this part of generative AI to avoid augmentation, to avoid the software creating phrases, diagnoses that you didn't mention. So whatever comes out of the note creation that the software is going to do after you finish the conversation with with your patient is going to be whatever you mention in this conversation, um, which becomes important because the burden that we get as physicians from medical documentation comes from different angles, right? It doesn't come from just having to write a note. It comes from the medical organizations wanting this note to be a medical legal document. They want this note to try to achieve different severity markers. They want this note to achieve a certain level of complexity that can be reportable. If your hospital may want this note to be so strong that no other payers can deny the claim that you are submitting with your note, saying that this patient was super sick and needed to be admitted to a telemetry unit as an inpatient level. That's the purpose of the organization, right? The organization wants to get your note to be like that. You want a note that is easy and fast to create and that has all the information put in a certain way that protects you from medical liability, that protects you from missing a diagnosis, that meets the criteria that the coders and billers in your hospital want from you, or if it's an outpatient office, that what they want from you. And ultimately, everyone also wants this note to be available for the patients in a way that they can understand what you are saying in your note. So see, there are different angles for this note that need to be achieved in order for this note to be effective in decreasing the burden that we get as physicians. So not just by creating a note, the software is helping us. And that's what we have to understand when we are looking to buy this software. We have to understand that to the basics, whatever you input into this software, whatever you talk into the computer, is going to come out a little polished, with a little bit of better wording, with a little bit of better grammar, but it may not come to the level of description, to the level of diagnosis accuracy that you want if you don't identify or dictate in your note what you want from this software to create. And so, since we said that every organization, every part that pays for this ambient software or for this generative AI software that you're going to be using, everyone has an interest. Everyone has something they want out of you getting this new tool. So the basics come to understanding what is good clinical documentation. And once you understand that, the process is super easy, and the outcome, the output of this software is going to be what you want. It's basically the same that you're doing right now by typing, by dictating on the phone. If you don't understand basic clinical documentation, then your note will continue to be the same, will continue to be poor, will continue to be used to deny your claims, will continue to fail at proving that the admission to the hospital is medically necessary, is failing at proving that the patient is very sick. So if you don't change your ways, the software is not going to do it for you. It's not going to save you time if you don't improve your knowledge on medical documentation, because you still have to proofread that note that was created before you sign off on that note. One major rule on the work generative AI is that there has to be human supervision, and especially in medical notes creation, there has to be human supervision. At the end, is you the one signing off on these notes. So that has to be clear. So far we have talked that for this software, whatever you input is what's coming out, a little more polished. So if you don't enter the information, the diagnosis, the clinical evidence that you want to be shown in your note, it's not going to come out that way. Second is, let's say we start dictating we start talking to a patient. Think about this system, this software is gathering all the information you are talking to it, that you are mentioning. So you don't have to start in a certain order. You could start saying, well, I'm going to go see this patient. I can see in his records that he was hospitalized at a different hospital. I can see that his white blood cell count today is 17,000, that he has bandemia, that he has a chest x-ray with a little bit of infiltrates on the right lower side. And I want to say that I myself read this x-ray and I identified a possible pneumonia. And then here I see that his oxygen saturation was 84%, which concerns me for acute hypoxic respiratory failure as one of the diagnoses. I think I'm going to admit this patient to inpatient telemetry. And my working diagnosis so far is 1, acute hypoxic respiratory failure secondary to pneumonia, 2, possible gram-negative bacterial pneumonia, 3, severe sepsis due to bacterial pneumonia. And the clinical indicator for this, for the respiratory failure, is the oxygen saturation of 84%. And for the pneumonia, the clinical indicator is the chest x-ray with infiltrates. And for the sepsis, I think I have leukocytosis, bandemia, I have a fever here of 39.4. And my plan is going to be to admit the patient to inpatient telemetry, to start him on antibiotics with ceftriaxone and azithromycin for the pneumonia, and continue breathing treatments for the pneumonia. And for the sepsis, I think I'm going to follow up on the blood cultures. And for the respiratory failure, I will continue with oxygen supplementation, consult pulmonology, and I want to make sure that there is an emphasis on the severity of this patient being very, very severe, and that if he leaves the hospital or is treated at a different level, he could put his health at risk. So I am recommending inpatient admission. Okay, so that's the basics I want on my patient. Now I'm gonna talk to my patient. So Mr. Munoz, tell me, why are you here? You're coming with shortness of breath. Okay, when did this shortness of breath started? Well, this shortness of breath started 4 days ago. So is it getting worse? Is it getting better? It's getting better. And are you having any coughing? Are you wheezing by any chance? Yes, I am doing this. So then you start talking to the patient like you always do for the HPI part, making a little bit of emphasis on review systems. You could say, well, do you have any abdominal pain? Do you have any headaches? Do you have any the same way that you go through your review system? Be, pay attention to how this part of the review system is going to come out on the note creation, because review system is very important for for you to achieve a certain level of severity with your note. For me as a hospitalist is to achieve a level 3. And you should also make notation at the beginning of the HPI who is providing this history. You could dictate there the patient himself is the historian as he's awake and alert. That's another point towards high level complexity in a medical note. Then you start dictating the physical exam. So now I'm going to do your physical exam. So I can see here that you are tachycardic with a heart rate of 95. I can see that your oxygen saturation is 94% on 4 liters. So on room air, you were 85%. You have to mention that in order for the software to identify it. But for each part of the physical exam, unless you have a way to dictate or say in this part at a normal physical exam, you may have to start saying, so neck exam, soft, non-tender, no distension of veins, cardiovascular, regular rate and rhythm, no murmurs, pulmonary, no crackles, no wheezing. You have to start saying your findings for the system to catch it and to categorize it as it is. And then it comes a very important phrase that I like to add on the HPIs is, what is the reason for admission that the ER doctors call you for? So I would like to say something like, oh, please make emphasis that I was called by the ER physician to admit this patient because he meets criteria for sepsis due to pneumonia, based on leukocytosis, chest x-ray, and he was started on antibiotics in the emergency department. So the system, the software, depending on which software you have, will identify those parts because it has been trained. The training of the software becomes important to see where is this software going to allocate this information that is key. And so then you go to the assessment and plan. You can say, well, now, Mr. Munoz, I'm going to explain you a little bit of what is my thought process. I want to keep you here in the hospital because your x-ray, your blood work are pointing towards pneumonia and sepsis. And sepsis is a very severe infection that has systemic signs and symptoms that are showing on you that put your life at risk if we don't treat you in the hospital with IV antibiotics. So I would like to keep you here, give you IV ceftriaxone, IV azithromycin, breathing treatments, get a blood culture set to make sure that the infection hasn't gotten into your bloodstream. And with all this, if everything is looking good and you're weaned off of the oxygen in a couple of days, I can send you home. But at least I would like to start this way. I would like to start getting these antibiotics, getting a pulmonologist to see you. And once we start seeing improvement, we can talk about your discharge process. So are you okay with staying in the hospital? Yes, perfect. Well, I'm gonna see you tomorrow. You close, that's the end of your conversation. You close it and then you push on creating the note. And you will see that the cheaper versions, the cheaper software are lacking on training, are lacking on how to allocate this information in a way that is that's meeting the criteria that you need for level 1, level 2, level 3 documentation, which is what hospitals want, right? Hospitals want a note to be able to reach a high level billing. Insurances, they want a note. They look into the note for those clinical indicators to not to deny your claim. They always want to deny your claim. So your employer will want you to have a note that cannot be denied. So the cheaper versions don't have that training. It's the bigger ones, the most expensive ones that have that training that knows how to allocate that. That's the difference. And that's why the free versions, the very cheap versions, I don't think that bring that much to the table because they haven't spent that much money or resources on creating this allocation. Ultimately, as long as you know each component of your node, the node that you're creating, it will come great if you know them. But if you don't know them, it will come as a very simple node that doesn't add to the severity of your patient, doesn't add to the level that you want to achieve, that doesn't add to the strength or the likelihood of a node to be denied. So it doesn't change what's going to happen when a denial comes to that node. You're still going to be called on why you didn't document that you are concerned about this patient, you're concerned about his pulmonary status, why you didn't mention that he has severe sepsis, why you only say leukocytosis, why you didn't mention IV antibiotics. See, if you don't mention it, it doesn't come, but if the software hasn't been trained properly, it won't identify what you're dictating either or allocate it in a way that you could use it. So my advice for doctors that want to buy this software is learn a little more about CDI, clinical documentation improvement, learn about the parts that your nodes need and how these have changed over the last years to a more specific verbiage or wording that needs to be in the node for it to achieve all these angles, to cover all these angles. With that, if you do that, then if you take some time to study that and learn that, then generative AI is going to be a great tool for you. You could really accelerate how you move between patients. But if you don't do that, generative AI is going to be a short-lived tool in your armamentarium. You're going to be like, okay, I still have to go through my node. My node doesn't have anything that I would like to see in my node. So I'm just going to go back to typing and go back to the dictating instead of using this tool. So learning more about documentation improvement, about what insurance payers want from your nodes, what your institution wants from your nodes, is going to be very important for this Gen AI in medicine to continue to move forward. And like I think it's not that Gen AI or generative AI is going to replace doctors. It's more that doctors that use generative AI will replace doctors that don't use generative AI. So I think that these innovations, these new tools are only going to grow stronger, and we need to adapt. We need to learn more about how to use them properly. So stay tuned. We're going to continue using more examples, more strategies to how to improve generative AI in our day-to-day as physicians, and learn more about documentation improvement.